Hello, we chose to discuss Cheryl Beck's postpartum depression theory for our mid-range theorists. My name is Jade Carrere, this is Brittany Mezquita, and this is Tiffany Roe. First, I'll talk about the theorist's background. Cheryl Beck earned her BSN in 1970, which she then worked as an RN on the postpartum and newborn unit. She graduated from Yale in 1972 with her MSN and midwife certificate. She then earned her doctorate in nursing in 1982. Beck became a fellow of the AAN and earned many awards over years for her research. She is currently holding a joint appointment at the University of Connecticut. Beck developed her theory to explain types of postpartum depression, risks associated with the disorder, and how to screen new mothers for the disorder. Beck's theory would be classified as a mid-range theory because it applies to specific nursing practice, maternal nursing. The theory can only be applied to a specific group of postpartum patients and has a highly specific tool which is used to identify the health condition of postpartum depression. Okay, the theoretical sources that Beck used contains of Jean Watson's theory of transpersonal caring. Although she doesn't directly state that she did use it as a source, she regards caring as a central concept of nursing. Colazzi's approach to phenomenology was also applied to Beck's first study. The research design, Teetering on Edge, is based upon grounded theory, or the realization that everything is data. Therefore, changing in the design never stops because a continuous amount of data is collected. Sickle and Driscoll's earthquake model describes the interactions between life and biology with the term biochemical loading. The model describes a fault line that develops over time due to constant chemical changes in the woman's life, which may not remain intact during highly stressful times. Empirics are known as research and observations performed before the development of theory. Beck developed her postpartum theory, known as Teetering on Edge, upon her research. Beck utilized 10 qualitative studies regarding postpartum depression from various cultures and locations in order to modify her theory to serve other cultures. Okay, the primary sources of the theorists that she developed, which describe the theory, is Teetering on Edge, a substantive theory on postpartum depression, and two tools that they developed to help screen for PDD is the PPD screening scale and the postpartum depression predictors indicators. Okay. Beck's theory of postpartum depression focuses on one specific client, the woman of childbearing age who are either pregnant or in the postpartum phase. The environment identified in the theory can be many things, such as the woman's home and family surroundings, the medical facility and staff who assist with the delivery, or certain situations that cause stress on the woman. Health, according to Beck's theory, can be either physical or mental. Both aspects affect the other's outcome. Lastly, nursing is viewed by Beck as a profession that is morally obligated to care for one's patients. Beck's theory of postpartum depression consists of 22 concepts. There are 5 types of postpartum mood disorders: PPD, maternity blues, postpartum psychosis, postpartum obsessive-compulsive disorder, and postpartum onset panic disorder. Loss of control is identified as the basic psychosocial problem of Beck's substantive theory. This concept occurs in all aspects of the woman's life and occurs in 4 stages: encountering terror, dying of self, struggling to survive, and regaining control. Concepts 3 through 15 are known risk factors or predictors for postpartum depression. Refer to the bottom left of the schematic where it lists all of these. Okay. If the woman has experienced any problems with any of the concepts before or during pregnancy, it is more likely for the woman to develop postpartum depression. Lastly, concepts 16 through 22 are a condensation of the risk factors mentioned previously, which provide a way to screen women for postpartum depression. And these are also listed on the schematic for the postpartum depressive symptoms. Next, I will discuss the major assumptions. Beck's theory portrays nursing as a caring profession with a moral obligation to our patients and coworkers. Persons in the postpartum depression theory are portrayed in terms of wholeness within the context of family and community. When regarding health, Beck talks about aspects of the physical and mental health as a result of the woman's response to her environment. Lastly, the environment of Beck's theory is assumed to include all factors of the individual that partake in the postpartum depression. The theoretical assertions of Beck's theory are based upon Sickle and Driscoll's model regarding the biological factors of postpartum depression. The theorists state that the brain can accommodate and adapt to a variety of stressors. These stressors can occur over a long amount of time and induce disruption of the biochemical factors which regulate the brain. Women are particularly vulnerable to mood disorders due to their unique hormone and brain function. Also, women are pressured by society to feel happy and look happy when they experience motherhood, making it difficult for the woman to express her true feelings. Okay. In summary, the theory continues to grow as more research comes into practice. Beck's postpartum depression theory was influenced by a number of theoretical sources and research studies to develop 22 concepts that predispose women to postpartum depression.
Next, I'm going to talk about our schematic. Since the book did not provide a schematic for Beck's postpartum depression theory, our group found and modified a model to adequately represent her theory. When developing this model, we had to take into consideration concepts 1 through 22, as these are vitally important to her overall theory. This is the schematic that we found. First of all, our schematic is broken down into two sections, the prenatal and postnatal. This is mapped with two arrowed lines that illustrate whether the characteristics directly or indirectly affect the outcome. The solid line indicates the main effect, while the dashed line indicates the moderating effect. The center of the schematic illustrates the importance of family characteristics. This is broken down into two subtitles, partner, maternal behavior, and infant reactivity. The other two characteristics of the prenatal period are parental acceptance or rejection and the mother's characteristics. The mother's characteristics go on to have two subtitles, the maternal behavior and self-esteem. Next is the postnatal period that contains postpartum depressive symptoms and maternal sensitivity. The prenatal acceptance or rejection has a direct or main effect on both the mother's characteristics along with the postpartum depressive symptoms. However, the mother's characteristics have a main effect on only the mother's maternal sensitivity. Each section described in the prenatal and postnatal periods can be highly influenced by the predictors or risk factors for postpartum depression. These factors are located in the bottom left of our schematic, and they correlate directly with concepts 3 through 15 of Beck's postpartum depression theory. Furthermore, these 13 risk factors are interrelated as they focus on a woman's overall internal and external influences that ultimately depict the woman's reaction to the prenatal and postnatal periods. When the mother begins to react to these factors or situations in a negative way, she will begin the 4 phases of loss of control depicted in the middle of the section. This is correlating with Beck's concept 2. This illustrates a precursor for postpartum depressive symptoms. The postpartum depressive symptoms correlate directly with Beck's 16 through 22 concepts. These symptoms are what the PDSS is intended to screen for. Lastly, the overall purpose of the outcomes of the schematic is illustrated by maternal sensitivity. All the predisposing factors correlate together to increase a woman's risk for postpartum depression or various mood disorders as listed under maternal sensitivity in the bottom right of our schematic. These correlate directly with Beck's concept 1. In order to properly screen, detect, and diagnose for postpartum depression, one must first understand the interrelationship of all the above concepts. Our schematic properly identifies and describes the major influencing factors and how they relate to the prenatal and postnatal woman. Next, I'll be discussing the logical forms. Beck's postpartum depression theory uses ground theory approaches to identify social processes that can occur in many different social events, and inductive and deductive logical reasoning. Inductive reasoning generates from the particular and moves to the general, while deductive moves from the general to the particular. Therefore, by incorporating both of these logical forms, along with a grounded theory approach, Beck can ensure her theory considers all aspects concerning postpartum depression. Flaws. However, since Beck's theory is relatively new, one may consider this a flaw due to the theory not being fully developed. But presently, the nursing profession utilizes Beck's PDSS along with her PDPI to assist with early detection and adequate treatment of the postpartum depressive woman. In fact, many research studies have proven the validity and the positive effects of her work. Beck's development theory goals. The main goal of Beck's theory has been to understand the postpartum depression in order to aid professionals to develop and initiate adequate prevention strategies along with programs for early screening and prompt intervention. Her theory, which began as a descriptive specific theory, has now developed and evolved into an extensive research program. Furthermore, there is ample opportunity for one to follow the process of Beck's scholarly theory development along with implementing the evidence-based strategies that her future research elicits.
All right, I will talk about nursing research. The postpartum depression theory, or PDT, is an extensively researched tool for diagnosis of postpartum depression. PDSS is a tool developed during the research of PDT by Cheryl Beck. She also did PDPI. Meta-analysis and qualitative and quantitative research has been conducted on this PDT model, extending the results and magnifying this model into modern nursing. Cheryl Beck began her research on PBD in 1972 and continues to this present day to research additional variables for this model. Education about PPD is a vital aspect of nursing of the obstetrics population. PPD is a serious illness disorder that can go undiagnosed with potentially serious ramifications for the patient, their families, and the new baby. The PDT is used to educate both undergraduate and graduate level nurses, as well as other healthcare professionals in all levels of PPD, and the interventions to promote a healthier state of mind for the new mom. The advanced practice nurse can benefit immensely from the information contained within this model. The PDT offers insight into the patients of the advanced practice nurse and allows for quick diagnosis, interventions, and outcome planning for the new mother. The PDT focuses on early intervention from proper screenings and treatment strategies adequately implemented to prevent harm of the female patients, their families, and children. This model equips the APN with sufficient skills to maintain the patient's health status during this difficult time of emotions. We did a clinical scenario. Ours was a 30-year-old Caucasian female. She presented to the clinic 2 months after the birth of her first child. The patient is newly married of 1 year to her husband, who works offshore and is currently away for the next 2 weeks. The patient presents to the clinic with black bags under her eyes, lackluster hair that's pulled into a messy bun. She's in an oversized sweatshirt and workout pants. The mother states that she has not been sleeping well because her 2-month-old baby only sleeps for 3-hour spurts. The NPO begins to assess the new mother and learns that the mother is struggling to pay bills and states, "I just feel so tired lately. This is not how I expected to feel once the baby was finally here. I feel like I cannot take care of her the way that she deserves." The NP begins to speculate the possibility of postpartum depression in her patient. She, the nurse practitioner, begins to recall the variables that indicate postpartum depression. The nurse practitioner refers to Beck's postpartum depression screening tool and asks the patient if she would mind filling out a self-report questionnaire to further evaluate the complications regarding her postpartum health. The patient takes her time to complete the questionnaire, and from its results, the nurse practitioner identified the following. Sleeping and eating disturbances, reported a positive loss of appetite, inability to sleep, especially when the baby is asleep. Anxiety and insecurity, reports positive feeling of insecurity, and being overwhelmed with a role of being a new mother. Emotional ability, there are positive reports of irritability. Mental confusion, she reports that she's having trouble concentrating and focusing. Loss of self, she reports that she is not able to identify herself as much since the birth of her daughter, i.e. there's a positive loss of personal identity. Guilt and shame, there are positive reports of thoughts of inability to take care of the baby. She says that she has a hard time opening up to her family about her feelings, and there are also positive thoughts of her being a poor mom. Suicidal thoughts. She did deny having suicidal thoughts of harming herself or the baby. Based on Beck's PDSS, this places the patient in moderate to high risk for or currently in postpartum depression. The nurse practitioner further evaluates the patient and formulates a treatment plan to help the mother cope with the new role and drastic changes in her life since the birth of her baby. The nurse practitioner is able to spot postpartum depression and effectively intervenes to deter any substantial ramifications that could occur for the patient and her immediate family in the near future. In summary, we say that postpartum depression is a serious medical illness as it can produce the most harmful emotions within the postpartum female. Postpartum depression can be underdiagnosed if the healthcare professional does not incorporate PPD screening with every patient interaction. Healthcare professionals should also utilize all the tools available for every patient outcome as well as postpartum depression. They can use PDPI and PDSS. PPD affects a great percentage of the population of new mothers or during pregnancy. Postpartum depression can be detrimental to the patient, families, or their new babies. The healthcare field as a whole is fairly undereducated on the ramifications of this clinical progression and can benefit from extensive education on clinical signs and signals and treatment plans for this aspect. And that is our presentation. Here are our references. Thank you.